Okay, good afternoon, everyone. We'll get started here in a moment. Before our first speaker comes up to get started, if you have not already, if you can download the NKF Meetings mobile app, this will allow you to do your pre-test, post-test evaluations here. You don't have to take that home with you. And if you click on the link for this session's title and then click on the poll button, you'll be able to enter any questions you might have during the course of the talks, and then we'll get to those at the end. Presentation slides are available on the mobile app and SCM portal depending on faculty permissions. And share your experiences on social media with the hashtag NKFClinicals. So, I am pleased to introduce our first speaker, Summer Van Arsdale. She is a registered dietitian and board-certified specialist in renal nutrition with over 15 years of experience in nephrology, including dialysis, transplant, and chronic kidney disease care. As the founder of the Kidney Nutrition Coach, she combines evidence-based medical nutrition therapy with compassionate counseling to empower both patients and professionals. Summer serves on the planning committee for the National Kidney Foundation Spring Clinical Meeting. So, welcome.
Thank you all so much for that welcome. Before we get started, I just want to say the polling app that you were just encouraged to either have like the app downloaded. We do have some polls in the beginning of my presentation that I would really love everybody to participate in. So if you could go ahead and just get that pulled up now, that way you're not scrambling to do that when we get there. I want to remind you that these polls are anonymous, so when you put in your information, nobody else is going to be able to see, and I really want it to come from your personal experience and what you've kind of lived to be able to really share that with everybody. So just have those up here. Is that not? Okay, so I have nothing to disclose as a part of this presentation for today. And by the end of my portion, we're going to be able to evaluate the weight loss interventions and really consider their utility in improving post-transplant outcomes. I want to just start off with the fact that a lot of times our patients are faced with this statement of, you just need to lose weight. And we're going to carry this theme through the beginning portion of this presentation, and we're going to reflect a little bit on our patients' experience in the healthcare system that's full of weight bias. So our first poll, I hope this works. Yes, okay, I got a head nod, thank you. Have you ever attempted yourself to lose weight in the past? And if so, how would you describe that experience? And if you haven't had to lose weight in the past, or that wasn't a personal goal of yours, I want you to think of another health-related goal that maybe you had. Maybe it was smoking cessation. Maybe it was meeting those 150 minutes of moderate cardiovascular intensity exercise every week. Whatever that might be. Thank you so much for participating. I think it's safe to say weight loss is difficult to achieve and even more difficult to maintain. And if you're saying this in this room as a healthcare professional, can you only imagine what somebody with lower health literacy, lower education, lower support, lower financial means is experiencing? Now, I'm curious, those of you who answered, whatever that personal goal of yours might have been, how much structure and support did you personally have during that process? And again, I really appreciate your participation in this. I think it's really eye-opening to think that 84% of you, as of now, have some sort of support. Maybe it was a spouse or significant other that said, I hear and I see your goal, and I will be here to support you through it. You need help prepping foods, you need help with motivation to walk every morning, I'm right by your side. Maybe you can afford a gym membership or have a safe place to go outside and take a walk. Maybe you have access to healthy food and no problem getting to the grocery store. And despite that, you said it was difficult to achieve and maintain weight loss or your personal health goal. So those are the only polls and questions, so thank you again for participating. So imagine your patient being asked to lose weight with limited or no support while managing a complex medical history and condition, being extremely fatigued, having multiple dietary restrictions in order to qualify for a life-saving transplant. Let that just kind of that weight sit on your shoulders for a minute of experiencing and maybe walking in the shoes of what our patients are being asked to do, especially those patients, obviously, who live in larger bodies. So I want to just kind of take this as an example of one of my clients, right? I've worked in kidney transplantation for over 12 of the 16 years I've been a dietitian. And this is all too commonly seen, this specific patient experience. And I feel like as a dietitian, the patients really can open up to me. I fortunately have more time to spend with them than maybe the 10 or 15 minutes that our medical providers have. But this is all too common, that when our patient is first diagnosed with, say, hypertension or diabetes, they're sitting down with their primary care doctor, whose intervention for the patient is maybe a prescription for metformin and the words to just lose weight. Then, later on, that same patient is later diagnosed with chronic kidney disease, and they're being referred to a nephrologist who said, this could be so much better managed if you just lost weight. And then that same patient's CKD progresses, they get referred for transplant, and the transplant center says, we cannot list you, you just need to lose weight. Weight loss in this scenario and the health bias around weight is taking under consideration that weight loss is our individual control and is therefore widely achievable. So if we think about how weight loss is happening, especially for this patient who's told to just lose weight, what resources, where are these patients turning? Well, of course, the thought is, maybe you're not trying hard enough because weight loss is simply calories in and calories out. I'm pretty sure everybody's heard that kind of terminology or that saying before, right? It's just calories in and calories out. You're not in a calorie deficit. We need you to be in a calorie deficit. But we know it's so much more complex and nuanced than that. There are several biological factors that determine weight. First and foremost being our genetics. Everybody in this room could eat the exact same meal for a year, right? What if we all were in a controlled situation where we were stuck in a room, we were given the same amount of steps per day, the same meals per day? We would all still live in different bodies. Our genetics play a huge role in that. We now see gut microbiome and gut dysbiosis being a huge indicator of that genetic component of our ability to lose weight. Hormonal regulation, and of course, adaptive metabolism. Medical factors, hypothyroidism, PCOS. Maybe these things are going undiagnosed. Maybe our patients are not getting a full workup with their primary care doctor now that they're under the care of nephrology. We know that happens way too much and shouldn't, but that is sometimes the case for our patients. Certain medications can cause weight gain or increase in appetite, like antidepressants, insulins, and steroids. And medical factors, lean body mass loss. We know a lot of our patients have a higher risk of frailty and sarcopenia, which we'll talk about a little bit later. But these are the medical factors we should be taking into consideration. Nutrition is a science and a behavior. And I say this all the time, and this is what makes it so complex. that there's very limited studies in nutrition because there's nothing we can bottle and then sell afterwards. So there's limited funding for what controlled trials are available. And the behavioral part of that is so important to understand, that we're essentially, what we eat every day, how often we move our bodies, is a very behavioral and lifestyle factor. So your sleep quality and quantity, stress, and again, hormones like cortisol, physical limitations and fatigue, and of course, our knowledge of nutrition. We also have environmental and social factors, our social determinants of health, food environment, food availability, access to healthy foods. And then psychosocial or psychological factors, including emotional eating, patients' relationship around food, and again, depression or anxiety that might lead to different food choices. And everybody wants to be a nutrition expert. So our patients who are told to just lose weight are given that one statement with no real support or guidance. So who do they turn to? They turn to the internet. They turn to social media and influencers, and their very well-intended neighbor Nancy, who wants to give them every diet advice. We're told that bananas cause belly fat. We're told that grapes are sugar bombs. We're told, have you ever tried this detox diet? Or just cut out carbs, right? You need to lose weight, just a low-carb diet. That will solve your problems. So if we're going to go for these fad dieting, this quick fix, because again, your patient is waiting for transplant. They want to be listed. They're going to go to extreme measures in order to have and achieve that weight loss. And also often we're bottling up these quick fixes as that solution for success. But we know very low carb diets, which unfortunately are also prescribed by healthcare providers. These include keto, carnivore, or Atkins, can cause insulin resistance over time, adaptive insulin uptake, really saving that for the brain while reducing that insulin sensitivity for the rest of the body. Limited long-term studies on metabolic outcomes are not available. When we see these promising weight loss or improvement in blood sugar control or whatever the condition is that we're trying to solve, these are very short-term studies. There's not long-term evidence-based to tell us the outcomes long-term. And then, of course, we're here for kidney health. And our kidney patients have these low-carb diets, they're turning to high protein. And that increases the potential renal acid load of the meal. High protein intake can then lead to metabolic acidosis and hyperfiltration. I had a client who actually lost 50 pounds while on the keto diet, and her nephrologist couldn't be more excited for her. But when she got her labs back, she now had a CO2 of 19 and lost about 15% of her kidney function, and her UACR was through the roof. And here she was told that weight loss would cure her disease progression. But how we're telling and how we're supporting our patients to achieve that matters. Diets are not benign. We also have quick fixes like intermittent fasting, where we have a restrictive eating time, right? We're only eating from 11 to 7 every day. And this really messes with our patients' hunger and fullness cues and can lead to disordered eating. Specifically, restricting calories throughout the day can lead to binge eating at night. We also have, detoxes and cleanses available, things like juicing or commercial products. And again, these are meant to be short-term. They can cause some muscle wasting or weight loss through diuresis, and unfortunately just can cause weight rebounding. And we care about weight rebounding because the literature shows us that weight rebounding increases inflammation, reduces metabolism, reduces lean body mass, and increases the biological drive to eat. We think about our genetics and where we came from. We think about feast or famine. Your body naturally wants to maintain its highest weight because that to us is survival. So when we're attempting to lose weight even intentionally, Your body doesn't understand that that is something that we're actually wanting to do. This is, no body, we have to trick you into this is what we need, this is what we want. And instead it's going to decrease your leptin and increase your ghrelin and make that biological drive to eat so much higher. So again, bringing this back to weight loss in our patients with end-stage renal disease or chronic kidney disease, only 10% of the patients with chronic kidney disease ever actually see a dietitian prior to starting dialysis. So we're already at a disadvantage with our patients to actually being successful, not only with healthy diet and slowing disease progression with a tool of nutrition alongside medical therapy, but we're also then giving them a dialysis diet, a transplant evaluation, and all of this additional information to just lose weight. And then again, there is the dialysis obesity paradox. We're asking patients to live in smaller bodies where the literature shows that this larger body might be a little bit more protective effect for them. When our patients are reaching dialysis, our dialysis dietitians are overloaded with patients. So the staffing ratio is usually about 1 to 120, and if nephrologists in the room, I know you care for many, many more patients than that. But again, nutrition is a behavior. In order to facilitate behavior change, we need to be having really great in-depth conversations with our patients to see what limiting factors and barriers there are and how we can help them overcome that. And then, of course, there's limited dietitians integrated into transplant centers. Most transplant centers don't even have a dietitian on staff full-time to provide this type of nutrition education and information. CMS does not require that a dietitian sees every patient prior to transplant listing. It's more based on the center's protocol, and that dietitians need to be available for high-risk patients. However your center determines high risk, maybe that is a BMI over 35, maybe that's a certain amount of weight loss or an A1C level, but this is where we really have that missed opportunity to provide education to all patients. So essentially, we're asking our patients to lose weight in a system that does not support them in this. But again, we're looking at BMI because BMI is a part of listing criteria. So I know a lot of centers have inclusions and exclusion criteria, some relative, some absolute to BMI, but that insurances also dictate this in some instances too. So we're going to talk about BMI because if we're going to use this as a tool to determine if somebody is going to achieve successful transplant and transplant listing, we have to know a little bit more about the use of it. So BMI was actually developed in the early 1800s by a Belgian statistician who really wanted to establish a quantifiable characteristic of the normal man. Normal for Europe, as you can imagine, is a white male. So this was really designed to look at population averages, not individual health scores. And so when we adopted BMI in the medical field in the 1970s, we're really putting a normal characteristic around an abnormal set of population. We're not taking into consideration different ethnicities, and we're definitely not taking into consideration what health really is. So we now use this widely, just due to its simplicity and standardization, but it is not meant to be used as an individual measure of health. Because BMI does not discern between fat and lean body mass, does not distinguish between where you hold that fat mass, gives no indicator of cardiometabolic health, and does not measure functional status. Studies in transplant outcomes based on BMI are often retrospective, and they are not adjusted for things like frailty or sarcopenia. So when we're looking at BMI alone in these studies, these historical studies, we're not seeing the full picture of what our patients' health is. So what do we do? If BMI is not a good indicator of somebody's health, what are other tools that we can objectively measure that would maybe give us a little bit more insight into how do we optimize our patients for post-transplant outcomes? Because of course we want to do no harm. There's not enough organs available to just be giving them away without really assessing that risk. So we want to make sure our patients are healthy and safe and ready for a successful transplant. So some alternatives to BMI, or being used in conjunction with, is frailty, sarcopenia, and waist circumference. So if we're assessing frailty, there's a lot of validated tools out there, especially the Fried Frailty Phenotype, which is listed at the top. I apologize for not having the full names and just the abbreviations there. But the components of the FFP include weight loss, hand grip strength, exhaustion, physical activity, and a walk speed. How you measure this is mostly self-reported. Of course, we can use a dynamometer for the hand grip strength, and we can actually map out 15 feet and time it. But as you can see, most of these are self-reported by the patient. The scoring gives us robust, pre-frail, or frail. Same with the short physical performance battery. However, this is a more objective tool. These are all measured by the clinician and use a walk speed, sit to stands, kind of our chair stands, as well as balance test, which is feet side by side, tandem, and semi-tandem. And again, gives us a criteria for robust, pre-frail, and frail. And although this last one is the Liver Frailty Index, used mostly in liver transplant, I think it's great to see that it's another tool that uses most of the short physical performance battery for its measurement, but uses also the dynamometer. And I love that because in dialysis centers, a dynamometer can be readily available for clinicians to have serial testing of hand grip strength, right? At initial assessment, at annual assessments, to really see, are we worried about lean body mass loss? Because checking that from a physical exam can also be very subjective. So we want to make sure we have some great objective measures in order to help our patients and identify their risk. Studies show that frailty and transplant evaluation here, that frail kidney transplant recipients were much more likely to experience early hospital readmissions regardless of their age. So when we see frailty, we're not just thinking of the 70-year-old coming in with a cane or using a walker. That frailty can live in anybody because, of course, we're dealing with chronic disease, and this is something that is not just biased to our elderly population. So if you are screening for frailty in your centers, I encourage that this is across the board, that it's not just specific for those who are ages 65 and older, but that it is screened for any age. Patients with pre-transplant balance score specifically with the short physical performance battery were significantly more likely to have early hospital readmission rates after transplant, as well as pre-transplant frailty was independently associated with almost a twofold increase in delayed graft function after kidney transplant. So all of the same issues that we're concerned about with people living in larger bodies, having larger BMIs, we can also see that same concern with patients who are frail. Delayed graft function, hospital readmissions, wound healing, a lot of these go side by side. So what do we do if we identify our patient as frail? We want to enroll them, if possible, in a prehabilitation prior to transplant. These results from a pilot study show that this was a single-center prospective study, and that patients who had met criteria for frailty based on the Fried Frailty Phenotype and the short physical performance battery were enrolled, and they were given a 1-hour assessment with the physical therapist, and then subsequent 40-minute sessions for an 8-week duration. The patients were also given a home PT exercise routine. And although they weren't able to measure that frailty again, they did have an activity monitor on these patients and saw that there was a significant improvement. Well, not statistically, but about a 64% improvement in the activity from baseline and then through the prehabilitation. So our patients were more active, they were more fit, more able to move their bodies. And 5 participants that did receive a kidney transplant during this study phase, and transplant recipients with the prehab had a reduction in their length of stay. So only 5 days versus the 10 days for those who didn't. So frailty is one tool we have. Measuring sarcopenia is another. So of course, sarcopenia, we're looking at the quality of skeletal muscle mass. So it's not just the quantity, it's the quality of the muscle. And of course, sarcopenia comes from lack of exercise, chronic inflammation, metabolic acidosis. There's a component for vitamin D deficiency, hyperparathyroidism, and proteinuria. We can measure sarcopenia in many different ways. We have BIA, DEXA, CT, and MRI. I know this does require some radiology techniques of finding the right area and measuring that. But this is if your patient has had some sort of imaging recently, this is something they can go back and measure for you. So in 2021, there was a retrospective study on kidney transplant recipients assessing that short-term outcomes again and compared to their skeletal muscle index. And those with a skeletal muscle index below the 10th percentile were associated with those longer lengths of stay in the hospital perioperatively, increased hospital readmission rate, and over a 12-fold increase in wound complications. And I know that we talk about wounds most often in our larger patients, so it is great to see that this is also something we should be looking for if we really want to enhance that wound healing after transplant, as well as a over 3-fold increase in graft loss or death less than 1 year post-transplant. And then lastly, something that's not new news, but not maybe being as utilized in practice day-to-day is waist circumference. So waist circumference is an alternative to measuring BMI. It's low cost and can give us more information about visceral adiposity. It's measured at the iliac crest using just a tape measure, right? One that will be bendable and easy to store in clinic. And in 2010, right, this is not new news, it's just not maybe used in practice so much, but patients with higher BMIs were associated with lower mortality in studies after adjusting for waist circumference. And higher waist circumference was more associated with higher mortality after adjustment for BMI. So again, it's not just living in a larger body, but it's how you carry that weight, where it's located, and your muscle as well. All right. So we have to think about now, we're not going to be able to change insurance's guidelines, right? Maybe the insurance cutoff is a BMI of over 35. So we're really tied into maybe what we have the ability to offer these patients at this moment. But I hope I planted the seed for you, just how difficult this is and maybe how BMI isn't a great measurement tool for helping our patients succeed after transplant. So if our hands are tied and we just have to help our patient achieve a certain weight in order to qualify for transplant listing, what weight loss interventions are available? We're going to go through behavioral, anti-obesity medications, as well as bariatric surgery. So of course, traditional weight loss. This is behavioral counseling. This shows that 5 to 10% of weight can be reduced after this behavioral type counseling within 6 months. It's accessible, low cost, has metabolic improvements, right? We'll see improvements in hypertension and diabetes markers, cholesterol markers, and has a very low risk of malnutrition or frailty, right? Very benign intervention to provide nutrition counseling and weight loss therapy. The challenges, of course, is long-term adherence. Once they're no longer with whomever, hopefully dietitian, helping them with these behavior modifications and education, are they able to be successful long-term with that weight loss? There's, again, that metabolic adaptation, increasing leptin and really driving that hunger. There's also environmental, socioeconomic, medical comorbidities, and social support not on our side with this long term. And then, of course, it's intensive. So if we have, right, anti-obesity medications. I know a lot of people want to use them to help support our patients, and the use of GLP-1 medications is rising. So we know that these are successful in helping patients lose weight through a combination of appetite suppression as well as reduced gastric emptying. Patients are seeing about a 10 to 20% weight reduction with the use of these medications. And although we are concerned about sarcopenia with the use of these medications, the only long-term study I've been able to find is the Semolene study that showed if your patient is successful at taking a GLP-1 for at least a year, that hand grip strength does increase overall. So there is an initial loss of lean body mass, but as the weight is reduced and your patient is able to be more active, right? Maybe it's easier to move around in a smaller body, that lean body mass is coming back up at 12 months. Of course, the challenges are to get your patient successfully taking this medication for more than 12 months, because we know it comes with a variety of digestive effects. A lot of these so intolerable that it causes an inability to continue with the medication. These medications are expensive and not always covered by insurance. So only those patients of means can really afford these. High risk of weight regain. So if your patient doesn't tolerate it, right, maybe tries it for 4 months, lost about 5 or 10% of their body weight and thought, this isn't worth it anymore. My side effects are no longer worth. I've lost the weight I needed to lose. I'm just going to stop this medication. It gets discontinued. Well, we're seeing the weight rebound. We're seeing that weight come back, sometimes even more weight. And of course, that lean body mass is what's lost initially. So when they're regaining the weight, it's not typically the lean body mass they're regaining. There's micronutrient deficiency risks, malnutrition risk, sarcopenia. Again, this stabilizes at about a year from what literature I've been able to find on it. And only by 1 year, only 33 to 50% of patients really can still take this medication. So just keep that in mind when you're prescribing this or recommending this medication to your patients, that it is a long-term solution, not a short-term solution. So really seeing if this is a medication they can afford and tolerate long-term is going to be essential if you're going to start this therapy. And GLP-1s still require lifestyle modifications. This is not a magic pill. This is something that even the insert for the medications recommend lifestyle changes, dietitian referrals. So if we really want to give our patients better outcomes, we really need to make this a multidisciplinary care approach. And of course, last but not least, weight loss surgery. And this can include gastric sleeve or Roux-en-Y. Both are still being done and studied in transplant. Indication for bariatric surgery would be a BMI greater than 30 along with a comorbidity. So of course, anybody of your patients are going to fit that criteria if their BMI is over 35. And of course, this is where we see the most weight loss, right? It's very rapid, it happens early, and can be up to 35% of total body weight within the first 12 to 18 months. Meta-analysis show that 50% of ESRD patients achieve transplant-eligible weight, and 29% receive transplantation after receiving bariatric surgery. So it is effective. We are seeing that patients are losing weight and that weight is allowing them to get listed for transplant. However, there's always a challenge when it comes to bariatric surgery, whether it's gastric bypass or Roux-en-Y. We have an increased risk of malnutrition. We have an increase of that rapid weight loss and increasing frailty, worsening frailty or sarcopenia. Vitamin and mineral deficiencies, especially with Roux-en-Y, we have high urine oxalate levels and oxalate nephropathy. And then, of course, really considering what those immunosuppressive medication changes might need to happen with having a malabsorptive procedure. So what do the studies show about weight loss in those patients who are pre-transplant, right? So sometimes we're just so excited, right, that we're seeing our patients lose weight. We're not always asking if it was intentional weight loss. So when your patients are coming into clinic and they're getting weighed, and then 6 months later they're coming in and you see they've lost weight and you congratulate them. Oh, I see you lost 10 pounds. Congratulations. That's so great. But how many of us are taking the time to ask our patients, was this intentional weight loss? What did you do to lose that weight? Are you moving your body more often? Are you making more nutrient-dense choices? We just put success in smaller bodies. But the studies show that weight loss unintentionally does worsen transplant outcomes. So this prospective multi-center cohort looked at over 1,300 transplant candidates, and they really just saw, despite their BMI, what were their outcomes if they lost weight unintentionally versus intentionally. And despite what their BMI is, unintentional weight loss was associated with higher waitlist mortality. So we can't just congratulate weight loss at all costs, right? We need to be able to dive in a little bit more and ask those questions to make sure we really are caring for our patients in the way that we're hoping to. We have another study here that was about 900 kidney transplant recipients, and they were looking at transplant adverse side effects, and again, unintentional versus intentional weight loss. And they showed that if there is intentional weight loss, if you are actively trying to improve your outcomes in terms of health and your body weight, that there was an improvement, where there was not as much of a decrease in their outcomes as those who unintentionally lost weight. So again, we want to make sure that when unintentional weight loss happens, it usually is increasing the risk for frailty and sarcopenia, and we really need to be thinking about what our patients are undergoing and how that might assess their level of frailty. So we need to reframe weight loss in kidney transplant and really all transplant. We need to think about fit for transplant versus being thin for transplant, because not all of your patients are going to be able to achieve a small body size, but still could be a great transplant candidate. Of course, we don't have the opportunity to just transplant anybody, because I know with living donors and abdominal size, we have an artery issue in connecting that artery up for living donors with people with central adiposity. So yes, I know that there's nuances around this, but for the most part, most of our transplants are deceased donor kidney transplants. So we have more availability for that artery size. So maybe we have a different way of viewing this body shape, body size, body components. Early RD intervention is really key. As you see, dietitians are underutilized in the CKD space, and if we're introducing this multidisciplinary connection early on, we have the availability to have these conversations sooner, to support behavior change sooner, and to really optimize this fitness and this overall health for transplant. We have medical weight loss options, but they should not just be prescribed and then forgotten about. There needs to be a lot of care, a lot of follow-up, and again, a multidisciplinary team to make sure that somebody is owning this. That transplant's not just saying they need to lose weight, we're prescribing a GLP-1, and then there's no follow-up or follow-through to make sure that we are achieving that outcome that we're hoping for. So the takeaways of my talk is that weight loss is obviously complex. And when we're trying to achieve weight loss in somebody with multiple comorbidities, it is going to be extremely challenging. The use of BMI alone is very limited. We need to be able to look at our patients from a very comprehensive standpoint in order to see what type of weight loss they need, how much, and if really they just need improved fitness. The use of GLP-1s in bariatric surgery are shown to be safe and effective in transplant, but timing, monitoring, and nutritional management is critical for long-term success. Again, multidisciplinary care is essential, and that we really want to make sure we are doing the best for our patients by whatever we're asking them to achieve prior to transplant listing. So we want to be able to give them that success that they're looking for. And of course, I have questions on here, but I know we'll do a panel at the end. So thank you very much. Okay, let me get
the next talk up. Okay. So thank you so much, Summer. Our next speaker is Dory Minch. Dory is a seasoned healthcare leader with nearly 20 years of experience in the nephrology and transplant field. As clinical manager of transplant services at Atrium Health Wake Forest Baptist Medical Center, she oversees operations that align with the mission and values of the National Kidney Foundation, where she has been a long-standing advocate and contributor. Dory has held several volunteer roles within the NKF, including serving as the past chair of the executive committee and as professional education chair for the Council of Nephrology Social Workers since 2016. Her career reflects a deep commitment to advancing kidney care, supporting transplant patients, and mentoring the next generation of transplant professionals. Please welcome Dory. Thank you.
It's fine. Everything's fine. We're all fine. So as I was going through my slides, I kept making revisions. So now I have some revisions on paper that we're going to go through. But thank you for that warm introduction. And thank you for inviting me to be a part of this panel. I have no financial disclosures with any ineligible companies. However, I would like to disclose that I don't live in the world necessarily of BMI. I live in the world of transplant and social work. So when I was asked to be on this panel, I was like, yeah, that'll be great. I know transplant. We have providers that talk about weight loss, surgeons that talk about iliac depth. I can do this. But as I looked into the barriers to access in transplant, it was a much different world. It's more than just sitting in that selection committee on Friday afternoons for us and saying, our one nephrologist has a flag for GLP-1s when a patient has to lose weight, and just, that's the trigger that these are the referrals that need to happen. It's what's happening before we even get to that room on Friday afternoons that's impacting our patients' ability to access transplant. And so a lot of the research I did for that, for this, surrounded that. So at the end of this presentation, I hope that learners will be able to identify how BMI impacts access to transplant for certain populations, and that we will be able to understand better how transplant centers can mitigate the disparity. So I, too, have a couple of polls. I just sort of wanted to level set to see where everybody in the transplant world, who is in the transplant world, or whatever local transplant center you work with, what your metrics and contraindications or criteria are around you. So very easy. Does your center or the center that you work with have a BMI threshold? Interesting. For those that do have a BMI threshold, I don't have this on a slide, but do you just want to shout out some numbers, the contraindication, the cutoff number for your center? 35. Okay. Now, does your center consistently adhere to your BMI threshold? Yeah, and that can feel kind of icky, right? So I know from our referral phase to our waitlist phase to the actual time of transplant when someone actually shows up at a weight or BMI much different than they were waitlisted at, it feels like some patients are allowed to come through, and it feels like some patients are held to a different standard than some others. And then it feels like some patients are held to a completely different standard than maybe your center even has. So I know that can be challenging. What is the highest BMI your center has transplanted? 40. I think this should let you put in a number, but I'm not sure. Oh, there we go. I was hoping it was going to tally them, but that's okay. Yeah, so I think the highest I saw in there was 48, which I didn't hear anybody saying that 48 was the cap of their BMI. So again, not adhering to the policies that we've created for ourselves. And then does your center use any other method in place of BMI? Assessment of CT imaging sounds a little subjective. We do that too. Yeah. So there's some other data that I have that'll bring this up too, but thank you for your participation in that. So BMI, who cares? There are many components of transplant that are influenced from BMI. From a macro standpoint, understanding how BMI thresholds may impact your waitlist composition is an important factor. Additionally, understanding its impact on your institutional reputation is important to consider. While some centers do prefer to be exclusionary, the transplant landscape is becoming exceedingly more competitive, and having a restrictive reputation can impact referral patterns. I know we see this sometimes with organ offers and our organ acceptance rate, and how we have to change those metrics to appease the people that we need to appease. These can also be influenced by patient experience reports and recent clinical experiences. In many cases, it's not what you say, but how you say it to your patient. Having guidelines, but making them patient-focused, can continue to instill hope in patients who may need to make lifestyle modifications. Finally, consideration of equity metrics. This, of course, does not mean holding everybody to the same standard, but flexing to support individual needs. And by having those shared conversations, we can really better align our patient safety and program goals. So I looked into some impact on the pediatric population and on the adult population. There is a rising prevalence of pediatric obesity, which has had significant implications to access and outcomes in kidney transplant. Obesity in children is associated with higher rates of hypertension, diabetes, and cardiovascular disease, conditions that both accelerate the progression of end-stage kidney disease and complicate their transplant candidacy. As obesity-related comorbidities exist, more pediatric patients present for transplant evaluation with complex medical profiles, often requiring prolonged optimization before listing. Additionally, obesity has been associated with surgical challenges, increased perioperative risk, and concerns regarding post-transplant outcomes, which may contribute to delayed waitlisting or reduced access to transplantation. As the population of children affected by obesity continues to grow globally, transplant programs must face increasing pressure to balance equity, safety, and timely access to life-saving transplantation. In our pediatric world, we have a very thin line between our pediatric nephrology department and our pediatric transplant department. And in our selection committee meetings, we often discuss referrals that might be coming to the transplant team. We had discussed for several months a 12-year-old female with a BMI of 53.3. We discussed her always coming back to the barrier that BMI had and her candidacy for a referral. Finally, our surgeon, who is very pediatric-centric, which is wonderful, had determined that we should at least proceed with the evaluation process to help her and her family understand the evaluation requirements and help determine the real impact of her BMI. While she still does need to lose weight, she is working to optimize the other aspects of her health in her weight loss journey. But again, as Summer mentioned, a BMI of 53 in a 12-year-old is far more than a weight problem. There's an emotional, socioeconomic context to that really requires more than just a weight loss referral for somebody in a GLP-1, which I don't even think she's eligible for. In the adult space, obesity is an increasingly common among patients with end-stage organ disease, as we know, particularly with kidney failure. While obesity is not an absolute contraindication in national guidelines, BMI thresholds can function in practice as hard stop eligibility criteria. This creates an unintended but significant impact on who gets access to transplant and who does not. Obesity disproportionately affects patients with lower socioeconomic status, patients from historically marginalized communities, and patients with longer dialysis vintage, who ironically may have sustained on dialysis because of their body composition. When BMI is used as a rigid gatekeeper, it can compound existing disparities in transplant access. And this is not about intent, it's about system design and its downstream effects. There is a push to reduce barriers to access to transplant, and we should be working to address these barriers. BMI and weight restrictions is just one of these barriers. Many of these populations may not have access to the food they need to maintain a healthy lifestyle, GLP-1s, exercise environments that promote weight loss. So this data was compiled using the U.S. Renal Data System from 2012 to 2014. Compared with those whose BMI was less than 35, persons with a BMI between 35 and 39.9 were 24% less likely to receive a transplant. Persons with a BMI between 40 and 44.9 were 21% less likely to receive a transplant, and persons with a BMI over 45 were 15% less likely to receive a transplant. And again, national bodies, the OPTN, AST, do not mandate BMI cutoffs. These thresholds are center-level decisions, and they're often driven by surgical risk, resource constraints, and historical practice patterns. As a result, access varies significantly by center, not by patient need alone. And from a patient perspective, this can be arbitrary and inequitable. We'll get referrals from a center just, an hour down the road. Well, why can I come here and I can't go there? Or I'm okay down there, why can't it be okay up here? And it's really hard to help patients understand the difference in criteria. The majority of U.S. transplant programs rely on BMI as a selection criteria, with 66 of the 67 transplant centers reporting the use of BMI thresholds, commonly ranging from 35 to 45. So I'm interested in the ones that do not have BMI thresholds and what you're using in place of that. Among nearly 158,000 dialysis patients not waitlisted, almost 40,000 were excluded from transplant consideration solely due to BMI in absence of any other medical contraindication. Notably, international adult transplant guidelines do not recommend excluding patients from transplant candidacy on the basis of BMI alone. BMI is an imprecise measure in the end-stage kidney disease population, as it can be significantly distorted through fluid overload and failure to distinguish between adipose tissue and muscle mass. Multiple transplant studies demonstrate that BMI alone is a poor predictor of mortality, graft outcomes, and cardiovascular risk compared with alternative measures of body composition and health status. Additionally, pre-transplant weight loss requirements and programs vary widely across centers, and evidence supporting sustained post-transplant benefits still remains limited. So I found this graph to be interesting. This reduced access exists despite evidence that transplantation still offers a survival benefit over dialysis for many patients with obesity. But it's notable to me that there is a higher risk of graft failure or death in patients over the age of 65 than there is for a severely obese patient. And our program loves that we will at least evaluate up to the age of 84, but we'll transplant up to the age of 85. But we'll be very quick to refer somebody for weight management or delay their listing due to BMI. So Summer went through some of these in her presentation, but as a newbie to this space, I have some descriptions of what these are. So these are some alternatives to BMI alone. CT-based muscle and fat assessment uses the routine CT scans that are often already obtained during the transplant evaluation, so it's not an additional test that your patient may need, to directly measure a patient's body composition rather than just relying on weight and height alone like the BMI does. CT imaging can objectively quantify skeletal muscle mass and fat distribution and can provide a much more accurate picture of nutritional status, functional reserve, and surgical risk. Sarcopenia is the condition defined by low skeletal muscle mass and or poor muscle quality and can be accompanied by reduced strength or physical function. In transplant populations, sarcopenia reflects a patient's physiologic reserve and frailty far more accurately than body weight or BMI. It focuses on muscle, not total body size. Waist circumference is a simple measure that just reflects central weight distribution and is more closely associated with metabolic, cardiovascular, and surgical risk than with overall BMI. Unlike BMI, waist circumference focuses on where the fat is distributed, not how much total mass a patient has. It also estimates the visceral adipose tissue, which is linked to insulin resistance, as Summer mentioned, inflammation, hypertension, and cardiovascular disease. Waist to hip ratio compares waist circumference to hip circumference and reflects body fat distribution, specifically at the portion of central fat relative to peripheral fat. And unlike BMI, waist to hip ratio focuses on where the fat is located, again, not the total body weight. Bioelectrical impedance analysis, I know Summer mentioned this, but just to describe what it is a non-invasive method that estimates body composition by measuring how electrical current travels through the body. Because muscle, fat, and fluid conduct electricity differently, BIA can estimate lean body mass, fat mass, and body water, information that BMI cannot provide. And rather than measuring size, BIA measures the physiology. It can distinguish between high BMI due to muscle or fluid, high BMI due to excess fat, or normal BMI with muscle depletion or sarcopenia. And then frailty evaluates the global physiological health across multiple domains, commonly including muscle strength, walking speed, physical activity, exhaustion or endurance, unintentional weight loss, and balance and mobility. These measures capture the real-world functional reserve, which is critical for transplant success. And I know our program several years ago developed our own little frailty test, which was a combination of the three that Summer had mentioned and is comprised of the dynameter, 15-foot walk, chair stands, the balance test, and a self-report. And that is used universally on every single patient. So we have an objective measure. And there are times when we have a 35-year-old patient that can't pass our frailty test, and we know that they're going to have poor outcomes. And so we have conversations that this isn't a no forever, this is a no for now, and help them with resources to get them to where they need to go. So I hope this information, which is a little briefer than Summer's, I'm sorry, provides you with insights and practice opportunities to share with your patients and your programs.
Thank you. So I'm going to invite Summer and Dory. We're going to start with a bit of a panel discussion, and then we also invite your questions. So again, put them in the app, or there are microphones that we welcome you to come up and ask questions. But we're going to get started just with a bit of a conversation here. I think both speakers presented good data that shows BMI is probably not the end-all be-all when it comes to assessing someone's surgical risk. And so we're not going to talk so much about like using BMI or why there should or should not be BMI cutoff specifically. I'd like to focus more on how, when patients are asked to lose weight, how does that impact either their access to transplant and how they feel about that and the support we offer. So to start, I think I'd like to hear from both of you. How can transplant teams discuss obesity without placing blame on patients who already manage burdensome disease?
So I'll take that first. I love this question because how we frame this to our patients when they're already undergoing transplant evaluation. I mean, it is a marathon, right, of the testing and evaluation conversations and meetings that really the team, I think, approach to this is very important. I think, coming together and saying we need you fit for transplant versus thin for transplant really comes off as an achievable and obtainable statement. Because again, most people who live in a larger body at some point in their life have been told that their body is wrong, that they need to change their body. So if we approach this more as an achievable way, right, we can all say, yes, we can improve our fitness more easily then we can control our weight. I think having this conversation could be a great way to start off of what we're asking the patient to do. And then as they're able to achieve that, really talk about what their success was and if there needs to be more weight loss depending on the center's criteria and cutoffs. But I think really approaching it more as not that, kind of in that shameful way of, weight loss, but more of physical fitness and the risk that being physically unfit and frail really poses to their post-transplant outcomes.
We have this conversation a lot, and in considering BMI, alternative BMI measures, especially frailty, our program has a lot of conversations about why someone's not a candidate based on weight and or fitness. And so as our coordinators have those conversations with the patients, or the providers have those conversations with the patients, I agree, making it not about the person, but making it about being fit for transplant. But we will often have patients maybe in anger sort of retort back, well, you couldn't pass that fit test, or you're not a candidate for transplant based on weight. And we can have some defensive responses to that. And so I think for patients to hear it in a different way and hearing, this isn't about you, this is about being fit for transplant, those conversations need to be very sensitive, for the patients. Providing resources and some objective ways that the patients can get there is also very helpful.
Yeah, framing it in a way that allows them to see that they can be successful is very empowering. So how you have that conversation absolutely matters.
And I think too, and I don't know how your center works, there are some patients that are closed out because of fit or frailty, and then there are some patients that are held because of fit or frailty. And I think when you're able to give the patient the opportunity to improve their fit or their weight over a period of time, and being able to have regular check-ins with them to say, hey, we're still here with you, and we're still encouraging you, and we really want you to succeed, rather than call them in 6 months, well, did you meet the goal? No? All right, well, you're closed, we're done.
Yeah.
That doesn't feel good to the patient, and from a referral standpoint at a transplant center, you're not going to get another referral from that patient. That patient's going to go someplace else, and if they're not coming to your own transplant center, they're not getting the best care. So.
Thank you. And I'm going to I work at Advent Health Porter Transplant Center as a nurse practitioner. I think explaining, so we don't have a BMI cutoff. It's very much case-by-case basis, and that was one of the questions. I guess University of Illinois also doesn't have a BMI requirement. I don't know if any of us know their outcomes, but for us, we don't see any worse outcomes in higher BMI transplants. Now, the limiting factor is what our surgeons think is feasible based on central adiposity. And so I think explaining to the patients that it's not just that we want you to lose weight. Here is the concern. Show them a picture. This is where the kidney goes, and as you can see, we have to get down to these blood vessels and the bladder, and that's going to make surgery much more complicated and risky given the amount of tissue the surgeons are going to have to get through. So explaining that, patients seem to really understand, okay, you're not just being discriminatory based on my weight, there is an actual reason for this. And then I think that helps them be a little bit more motivated, in my experience. I don't know if you have noticed that as well. I think we're getting questions in. So one of the questions is, can you talk a little bit more about the dialysis obesity paradox? And that kind of goes to my question, which is also, when we do recommend weight loss, how do we deal with the risk of then sarcopenia and increased frailty?
Yeah, so this is kind of like a multi-layered question. So I'll just start with that obesity paradox. There's literature showing that specifically a BMI greater than 30 for those patients on dialysis does have a protective mechanism and effect. And I'm not sure we really know the exact details why, but we see lower BMIs than 30 having a higher risk of mortality on dialysis. And so if we're asking our patients to lose weight, and really it was baffling to me to see that some centers had a BMI cutoff of about 30 or 35, because that is really excluding a lot of patients for transplant candidacy. But if we're asking them to, achieve a lower BMI or having weight loss medications, what is that balance for them? And I think that this is getting lost because there's a gap in care. We have a prescriber, we have someone initially saying the weight loss needs to happen, but then we have no ownership of how well they're doing, how well they're tolerating, and how we can help them kind of optimize their entire status and not just that weight loss itself. So I think, again, intentional versus unintentional weight loss in the literature shows it matters. It matters for weightless mortality. It matters for post-transplant outcomes. Did I answer all of that, or was there more? Because I know there was 2 parts to that.
No, I think that,
Okay.
yeah. I mean, and because we want them to lose weight. Obesity is protective in dialysis, but then we're asking them to lose weight, and then are they losing muscle mass?
Yeah,
Which
and
then
also
puts them at even more risk.
Again, that's
for
like such a
transplant.
great point. It's like that lean body mass. We know that that's like the most protective element for our patients. So think about your patients on dialysis. How many of them are walking into the center? How many of them are physically active in between dialysis? Most of the time my patients on dialysis always said, this wipes me out so much, it takes me the whole next day to recover, and then I'm right back here. So we know they're not participating in physical activity, and we know that their mobility is limited. So dialysis is just a breeding ground for frailty, right? We're not given a lot of recommendations to exercise and be physically active. We're talking about phosphorus levels. So this is where that dynamic and that shift really needs to happen to what are the conversations we can have that are going to be able to be helpful in promoting transplant, because we know outcomes and mortality and survival and quality of life all improve with transplantation, and we want this to be that modality of CKD treatment for our patients. How do we allow them to be successful in that?
And I think too, much like when I worked in the dialysis center, we sort of had 2 tracks of patients. We had our patients that were on the transplant track, and they needed to be independent. So I wasn't making transportation arrangements for them. I wasn't calling their provider to help them get a refill. I was teaching them how to do it, but I wasn't doing that for them. And then we had patients that we knew would never be a transplant candidate for their comorbidities or other factors that prevented them from getting to transplant. Is there anything wrong with having similar tracks from a dietary perspective? Is it okay for our patients that are not going to get to transplant for reasons, because there are some that are just never transplant, to have that, protective weight versus working with patients who are working to get to transplant and maintain a little healthier BMI that will support them in transplant? I don't know.
And again, getting patients referred early.
Yes, yeah. Along this line, how should teams support patients who are trying but not maybe being as successful as we would like to meet BMI targets? So what resources make weight loss more realistic? And do we see this happening at the transplant centers, or what is the transplant center doing to support this?
Yeah, dietitians exist. Our whole career is focused around these behavior changes to make patients successful in slowing disease progression, optimizing dialysis outcomes, transplant outcomes. And if you don't have a dietitian in your interdisciplinary team, it's time to get one or find one in the community. NKF has a whole list of dietitians that are CKD specialized in private practice online. It is time to utilize the healthcare professionals who want to own this. So the gap in care, again, is not utilizing the resources that are available to their best capacity. I also would say, from a transplant perspective, I am one of very few transplant centers in my history that the transplant team owned the dietitians. We were under their FTE, and that made a significant difference in what we were able to provide to our waitlisted patients, our post-transplant patients, the continuum of care. We saw patients at the time of referral all the way up to 3 years post-transplant. We owned those patients, and our SRT, our data reflected that. Our hospital readmission rates reflected that. And we had higher BMIs, and I'm from Arizona where we have a lot of elderly patients too. So we were a very aggressive center for being small, but we had a robust, dynamic dietitian team. And I think that that really is the gap in care. I'm also very obviously biased with that, but I think that that's a big gap of care that I'm not seeing in nephrology institutions and outpatient practice, understaffing in dialysis centers, and then again, a dietitian not being a focal team member in transplant.
So were you seeing RDs offering ongoing nutrition counseling to patients on the wait list who were asked to
we
lose
owned
weight?
them.
Okay.
Yeah. Anybody that was frail, had high A1Cs or some sort of reason why we said you are not a transplant candidate, we then followed those patients and had regular phone check-ins and visits with them and helps them achieve the goal that they were looking to have.
That's great.
Yeah,
I would say
that was
that's
great.
not been my experience working at two centers that did have RDs under the transplant center's FTE. I don't know about anyone else, but our dietitians would do assessments, they would do frailty, they would make recommendations, and then we kind of told the patients, please lose weight, figure it out. I mean, even with weight loss medications, our doctors, we don't prescribe that. We say, ask your primary nephrologist, ask your primary care, ask your endocrinologist. We do make referrals for bariatric surgery, but we really don't get involved in actually
Yeah.
assisting them to
And
lose weight.
I think that again, even in a bariatric surgery center, making sure that you're referring to a center that you understand who their team is, right? You understand what their success rate is. You know that they have a dietitian on board, because a lot of, in private practice, I have a lot of patients who have had some sort of surgical intervention, bariatric surgery, who were told, oh, I never saw a dietitian. There wasn't, any real counseling of anything besides what to do to care for myself immediately post-operatively. So I think that it's obviously a gap in care in many areas.
My experience is similar to Nicole's. We don't have a dietitian under our transplant umbrella. They review our agenda for selection committee. They send out the ones that are eligible for referral. Orders are placed. Patients don't call back, and then it goes away, but the effort was made. We used to have a dietitian that would come to our post-transplant clinic once or twice a week for like 2 hours. So if you were lucky enough to be there on Tuesday from 8 to 10, maybe you saw the dietitian. But obviously that didn't capture everything that we need.
Yeah.
But I know our program has made some changes in bringing different disciplines under the transplant umbrella, so that's a really good thing to take back.
Well, and also, I know the bottom line is money, right? And it costs money to staff a dietitian, but dietitians are billable providers. You get reimbursement for the time a dietitian spends with your patient, or again, the data and the outcomes, right? We know that Medicare does not pay for hospital readmissions after transplant. So what is the cost benefit, right? Is it reducing length of stay? Is it reducing early hospital readmission rates? The dietitians pay for themselves within your center, whether it's value-based care or the administrative bottom dollar for hospital readmissions. We don't make that much. So we will pay for ourselves in terms of what the outcomes are and what your patients are experiencing. And I think that that speaks for itself.
And it's probably cost reportable.
Since you do take ownership of these patients, do you see other medications besides GLP-1s being utilized? Are there digital solutions that you recommend patients can use? Can you tell us more about how it works?
So I have unfortunately now been out of that transplant center for almost 5 years, so I don't know their current practice and of course the landscape for these medications being more readily utilized for weight loss, so I can't speak fully to that. Mm-hmm. But we did have kind of a prehabilitation guide that, depending on your score for, we use the short physical performance battery as our frailty scoring system, and whether you were pre-frail or frail, you were received kind of like a mobile prehabilitation video, and you were expected to do those exercises at home on your own. And we had regular check-ins every 12 weeks with them. And then you would go to the next video or the next phase after that. So we use nutrition counseling. We talked to dialysis centers, and we really just tried to create a program that allowed patients to seamlessly flow through without, again, having, more team members that needed to be involved in like an in-center prehabilitation program. So we developed our own kind of patient-centered and led.
Let's see. Okay. I will say, we don't manage the medication prescription for weight loss. But I have seen people going to medical weight loss clinics and being prescribed other types of medications besides GLP-1. So that's where we don't really feel like, as nephrologists or transplant surgeons, that's our area of expertise. So we leave that to the specialists. Okay, we have two people. Okay, Miss Red Shirt.
Thank you. Hi, everyone. Clarissa Diamantidis, Wake Forest. Hi, Dory. So this was excellent. Thanks to you both. So I work sort of on the transplant research side of this. And so we have some studies and programs trying to promote early and equitable access to kidney transplant. And I think a lot of what you guys have relayed, anecdotally, I understand. The barrier that I have seen in the works that we're doing is really on the nephrologist side, pre-transplant referral side, where our goal is really to get everyone to get transplant on everyone, so that you, as the informed transplant providers, can provide that education and intervention. But we've had a lot of pushback from general nephrologists about referring for transplant, knowing that folks are ineligible based on BMI. And I'm just wondering your thoughts on that. And we push back, and what we've done is we've done self-referrals. We've had social work help patients with the referrals, and sort of circumvented the nephrologist to put in the order for the referral. But I'm just wondering your thoughts on sort of the pre-transplant referral, what I will call bias in terms of obesity and transplant eligibility.
Just speaking from my experience, I think that there are programs that don't have a hard and fast BMI cutoff, and I think it's just really important that they then communicate that to potentially referring nephrologists to say, you don't need to limit who you're sending to us. Send us whoever you feel like, if they're meeting the criteria where their GFR is at that certain point, or they've been on dialysis, just refer them. And most centers, I think, have kind of what they might call referral review, where their teams will hopefully review the patient's specific case, and then say, okay, yes, we're going to reach back out to the nephrologist, and they can be re-referred when XYZ is met. Or our program will have a nephrologist-only visit, so it's not the full day's panel visit with everyone. They'll meet with the nephrologist, and then, again, sometimes people look worse on paper, sometimes they look better on paper, and so that allows for more individualization. I think it's really building relationships with the transplant programs that are they're referring to, and that's easier said than done. So maybe finding out what centers are a little more open based on weight and BMI. I don't know. What are your thoughts?
So I know we are a center that has BMI criteria, but does not always adhere to BMI criteria. And we do have a referral intake team that reviews all those referrals. And for any patient that's not a candidate medically, one of our referral coordinators, nurses, will reach out to the patient and guide them in what they need to do to become a candidate. So it can reinforce what the nephrologists are thinking, or provide a completely different track, and maybe they are eligible to come through because the surgeon reviewed the CT and they feel that they're a candidate, and they can make it work, but would encourage some weight loss. But I think even the referrals for those that are not, or they feel are not candidates, there's a lot of value in the transplant coordinator having a conversation with the patient, and maybe can get them to hear the goal in a different way. And I always say, let the transplant center be the bad guy, because we get to deliver a lot of good news. We have to take the ownership in delivering the bad news, and patients who are not transplant eligible need to maintain the relationships with their providers because they need to stay with that provider long term.
I would just say from my experience, we want the referral because again, BMI is not the end-all be-all, and sometimes we are able to successfully transplant and have great outcomes if the patient is robust and has other, criteria that is in their favor for healing post-transplant. So again, I would call the center that's local to you and see what their criteria is, because our center would, when you get a referral, BMI would never exclude you from seeing the team, but of course other things like active cancer and would. So we do obviously do those screenings, but BMI was never one of those. I had a physician surgeon champion for fit for transplant, so we made sure to see and assess everybody.
Thank you.
Yes.
Go ahead.
My name is Candace. I'm from a practice in Pennsylvania, small practice, but I wanted to talk about the dietitian. I worked for a very large private practice in North Carolina that we basically stole a renal dietitian from the dialysis unit, and she had a private practice. She saw patients in our office 3 times a week. It was marvelous. She saw post-transplant patients. It was the best thing we ever did, and she was worth her weight in gold. She really was. So if you have a practice and you can get hooked up with a dietitian who is really good and really understands that, you won't be sorry. That's really good. I also wanted to mention, we were talking about weight and mortality. You might remember it was a very old study 20 years ago on with liraglutide and Victoza, and it ended up, it was in dialysis patients, and the study started out being safety of using liraglutide in patients on ESRD. There was an arm of the study that showed, because we're always telling people you got to eat, you got to, the weight issue, you've got to eat, you've got to eat protein, all that kind of stuff. And there was an arm of the study that showed higher mortality in dialysis patients that had that lower BMI because they had lost weight on liraglutide. So I think that is something that we don't always think about, that those low BMI and that those people with the weight loss and the muscle mass really do have a higher mortality. So I was just thinking about that. I was going to ask you another question about the transplant. I agree. We send everybody who wants to go to transplant, because if we're, as the nephrology team, I'm a nurse practitioner, I've worked in nephrology for 27 years. If you try to tell that patient that they're not eligible, they get really mad at you. So we just say, I'm going to send you to transplant and let them do that. I've started to see a real, I think, a paradigm shift, though. They're really strict with the BMI. I mean, they are absolute. But one of the things that we've seen is that I had a patient the other day that she gained weight. She now became ineligible. They took her off of the transplant list, but they referred her for workup for gastric sleeve. I have another absolutely wonderful patient. I just love him. He's a class 3 obesity. He was a smoker, and at one point they would have never, ever even talked to him. They are giving him a period of time to stop smoking. His insurance plan would absolutely not pay for Mounjaro because he wasn't a diabetic, but they referred him for gastric sleeve. So I think you're also seeing a lot more of the transplant centers who say, we want people to be transplanted. And they're being more proactive in trying to help patients to get that criteria so that they are eligible. But
yeah, and I think that just goes back to, it's not weight loss at all costs.
No.
It's making sure that we're achieving what we set out. Our goal is, right, is for better post-transplant outcomes.
Yeah.
And we can't just say all weight loss is the same. And we also, our weight bias. Not everybody living in a thin body is healthy and reliable for good post-transplant outcomes. I think, when we celebrate weight loss without really seeing the underlying cause or effect of that, I think that I think it's very misleading and not to our patients' best.
Yeah, I was happy to see that our transplant center is really starting to offer a lot of other services and to be able to help patients become transplant ready, which is really encouraging. So that's good. So this was really good. Thank you. This was a wonderful, wonderful lecture.
Thank you.
Gentleman at the second microphone, please. You, yep.
Thank you. So I'm Andy Salmon. I'm a nephrologist from New Zealand. Thank you for a wonderful session that's been really interesting to hear your perspectives. I work in a system where we have an absolute BMI cutoff at 40. There are inequities in terms of what that BMI means for our different populations. With our Māori and Pacific people, a BMI of 40 is not the same as it is for our Pākehā patients. The question I have for you is about the journey that your centres have been on from becoming from a situation like the one that we face, which is in contrast to the KDIGO guidelines, which says do not exclude people solely on the basis of obesity, to very enlightened sounding centres in which you have a panel of metrics that you look at and some kind of individual case-based decision making. So my question is around the journey that your centres have been on, and what do the success factors in your centres look like that we might be able to reproduce? Is that just down to individuals? Is that down to passionate leads of people who set the decisions? Is this around a culture shift? Is it around guidelines? What have you seen in the system that makes that shift possible?
I think it's a champion. So at our program, we have a nephrologist who, has looked at the data and feels very strongly and has advocated very strongly about, outcomes are worse staying on dialysis than transplanting someone with a high BMI. And so we're doing a disservice to these patients by leaving them on dialysis. And then we have, luckily, some surgeons who are willing, again, to take that kind of surgical risk. So that has made the shift, because I've been at 2 different programs at the program I'm at now. So I think it's someone who can really look at the data and then champion that, and then having a surgeon, because really that's what it comes down to, surgical risk. And so it's having a surgeon who either is comfortable taking that risk or is exploring the newer options like robotic surgeries for higher BMI individuals that make the surgery less risky. That's how I saw it get implemented personally. I don't know if y'all have.
Our surgical director, our medical director of our program, always likes to push the envelope. And so when we transplanted a BMI of 52, that made the annual email of our accomplishments for the year. And I think when we saw success in that, there was some windows opened up. Well, maybe we can do this a little bit more. It doesn't mean, though, that the care provided afterwards, which is often by our APP team and our nephrology team, doesn't become more complicated. And so there does become some tension there of is this safe? Can we provide the best care for these patients who are higher surgical risk? But I do know that we all have the passion to get people off of dialysis and provide the best care for them. And it just looks different, I think, from the lens that you're looking through it.
I couldn't love this question more. And I think it really is a shift in perspective of what we're really asking to achieve here. And I just think it's one of those things where we're looking at someone's body and deciding if they're worth saving with a transplant. And this type of weight bias doesn't happen in other areas, right? And where it shifted for my transplant center was we were in selection meeting and we had a very fit, cardiovascularly in shape person, and we had an absolute BMI cutoff of 35, and her BMI was 36.5. And she was more fit than most of the patients we were transplanting. So I remember this very vividly early in my career, where our surgeon said no. And I said, instead of asking her to be smaller, can we ask you to be better? And he looked at me and was like, okay. And I said, we're asking our patients to live in smaller bodies, but why aren't we just trying to advance the surgical side to accommodate the bodies that we are seeing in real life? And it actually opened up a really great conversation within our entire transplant team. And then we had a surgeon champion who looked at this from a different viewpoint. And really, we're asking you to look at the patient from a medical comprehensive view and not just through our lens of thinner is better.
thinner is more ideal, thinner is sexier, thinner is healthier, right? We know that that is not the case, that chronic illness lives in every size body, and people who are thin aren't necessarily inherently healthier than those in a larger body. And I think those are the conversations, and looking at the data, again, it's old, it's retrospective, and it doesn't include frailty and sarcopenia. So now that we know better, we can do better and have better research and better data to have these really meaningful conversations.
Thank you.
Thank you. Okay, we're getting close to our time, but we'll try to fit the last 2 questions in.
Mine will be quick. It's mostly a comment. First and foremost, one of the things that you guys reiterated over and over again that I was very resounded with me was the idea of just refer. Let you all be the bad guy. And I think that that's something that you don't know how to handle, knowing that somebody is probably ineligible. So thank you for reiterating that time and time again. The other thing to comment on the woman's comment earlier and to plug Summer. Summer tomorrow is chairing a session entitled Dietitians in Your Nephrology Office, From Clinical Impact to Income Opportunity. So we will be reviewing exactly that idea of how do we help our people earlier.
Thank you.
Thank you for your presentation. I am a nurse practitioner in the Veteran Affairs Office, and one of the privilege that every veteran has is to go anywhere in the United States to get transplant. But we have to refer them to you guys. So most of the challenges that we face is that when we see these patients and they face with these challenges of overweight, and we make the referral, but we have to get them back for management. What strategies have you used as a referring center that you can share that will help me to involve the team? Because as a referring center, we're seen as a consultant team, not really a management team. So for me to make a diagnosis of referral for weight management, I have to be first diagnose weight management. So it becomes challenging to really refer those patients to see a dietitian to really help them and then go to weight management. How can I mitigate to maximize these patients so that I can refer them to a transplant center?
Yeah, I think to reiterate, refer everyone. We can then, if we feel like weight is a barrier, we can let patients know and discuss why. We don't, again, manage, even though, yes, we're able to prescribe medications, GLP-1s or whatnot, we don't manage these patients long-term at the transplant center. You know, they're only seeing us like once a year while they're on the wait list, and then after transplant, of course, we manage them. So we can't really get involved in prescribing weight loss medications because we're not going to be seeing them like every month to assess their status. So I think it's, if you are comfortable taking ownership of those medication managements in the nephrology offices, that's great. I think, you know, there is one, semaglutide, that has coverage for kind of slowing the progression of CKD, so that might be a little bit easier to get covered. I think the biggest barrier of GLP-1s is getting insurance to cover them, especially if someone's not diabetic. Sometimes I've seen providers then order like sleep apnea testing, because then if they have sleep apnea, they can qualify. So if your office is comfortable kind of taking over the medical management for weight loss, that's great. If not, some primary care is, or if you have weight management specialty that you can refer to, I think that's the best option. So we have a few, like Kaiser has weight management. Some of the universities near us have weight management clinics, so patients can get referred there, and they offer the behavioral support, the nutrition support, and then medical therapies as well, if that's indicated. Does that answer your question?
Yeah, in a way it does, but in the VA system, I cannot really assume care for those patients because of the area where I am, so kind of difficult. But I was hoping if there are other things that the transplant center have used to justify having referrers to those that can help me use as well to justify in my own practice to get in that team to be able to allow those patients to be seen and care be followed by them. So, for example, for me to refer to nutrition, the patient has to have malignancy, poor nutritional intake. So I
Sounds
can't
like more
just
of
say
like a
because
system.
they're obese, go see a nutrition for food choices, management and selection and counseling.
Sounds more like a system
Yeah.
that needs to be fixed in the area, right?
VA.
Yeah.
Yeah.
I think, that's again, the reason why we have these conversations, and that you can bring it back to your team to really see what opportunities are available to help that out. But it's still something we're obviously still working towards. Thank you.
Thank you.
Thank you
Thank you,
guys for
everyone.
coming.
We appreciate your attention and joining us for this. Thanks to our speakers.
Thank you.